I need to say a word or two in light of the fact that there is what we will talk about, an industrial strength campaign to censor this story, and I need to say something rather directly to those who are most likely to attempt to censor it. What I want to say is that Dr. Kory is not only an advocate for a therapy that is incredibly useful in the context of COVID-19, but he is also someone who has pioneered therapies already that are now the standard of care for COVID-19 patients. That means he has earned the right to talk about whatever he thinks is important. For my part, as you know, I was also very early on the lab leak hypothesis, and I was very careful about how I presented it. And of course, in the last month, that hypothesis has been vindicated. Everyone, including Dr. Ralph Baric, who is the leading expert in the world on bat-borne coronaviruses and their modification in the lab, has acknowledged that a leak from the lab in Wuhan, China, is plausible. I have also earned the right to talk about what I want to talk about and what I think is necessary. We are now going to have a conversation, and if you don't like it, that, YouTube, is your problem. We are entitled to discuss this because a lot depends on it. And what we do when issues are complex is we hash them out and figure out what's true through dialectic. So that's what we're going to do.
There's another area in which we're failing at treatment. And I find it not as egregious as the ivermectin, but the corticosteroid issue, that when we came out and recommended it, 6 to 8 weeks later, Oxford did the recovery trial, which proved to the world that corticosteroids were life-saving. To say that we said, we told you so, we got past that. But here's the travesty of it, is the Oxford trial used this tiny dose of corticosteroids. They used a dose lower than what I give my 80-year-old patients with emphysema when they get a little sick. I give a higher dose to them. They're giving this tiny dose to people crashing on ventilators with horrifically inflamed lungs. It doesn't, when you're talking like what's sensible? Mm-hmm. And they also give it for a time limit. They give it for 10 days, as if the disease has been determined to last for 10 days, and there's nothing that makes sense. We know that higher doses are needed. We know that longer durations are needed. There's no research going on into looking at other protocols. And the entire world, this country, every doctor, every sheep of a doctor in this country is following remdesivir, 6 milligrams of dexamethasone. That literally in all the health systems are telling them this is what you should use. If you use a higher dose, you're off protocol. And in some places, you're probably going to get feedback for that. I use very aggressive dosing strategies for longer durations. I think there are quite a few doctors who are, but the official NIH one is this tiny dose of steroids. And that dose, and I can assure you I have tons of data, it helps the few and fails the many. There are many, many patients dying in hospitals of inadequate treatment of this disease with an anemic dose of steroids. Just to add it to the list of stuff that doesn't make sense.
Okay, so I was just going to say, what this is it is more evidence of a gravitational force from an object we cannot
But
see.
that one, I don't know if that's a sinister. That one's just stupid. That's just I just don't know. Where are the doctors here who are saying like what I'm saying, which is like the dose of steroids doesn't work. I've now published 10 papers on COVID. The one that I think is the most impactful, the ivermectin is probably pretty huge, but myself and one of the top chest radiologists in the country, if not the world, we wrote a paper saying that this disease is actually not a viral pneumonia. It's an organizing pneumonia. The mainstay of therapy for organizing pneumonias, which is a non-infectious pneumonia, is corticosteroids. And in fulminant cases, we know over the decades in treating, you need high dose steroids. Nobody's paying attention. They're still treating this with this little anemic dose. It's bizarre.
And the obvious thing to do, right? Were I a clinician, and you tell me if I misunderstand what doctoring is about, but were I a clinician, I would be tempted, right? To the extent that there is some dose that I'm told is the right one, I would be tempted to see what happens a little higher, a little lower. Oh, the higher works. A little higher. right? You would find whatever dose worked best at the point that you just nudged it a bit, right?
Yes.
So the idea that there's some God-given dose is absurd.
The God-given dose is what was tested in the trial. And that's where I find randomized controlled trials. It's another reason why they're very unsatisfying, because they tested one protocol.
Thing, right.
It doesn't mean that's the only one, but the world is taking it as that's how you treat COVID.
That is maddening.
It's mad. And the other thing is, what I know is my guess, and I haven't talked to those investigators, but my guess as to why they tested such a low dose is because they were literally fearful that it was going to be harmful. So they on purpose tested a low dose. And I actually find that one of the greatest tragedies that we came very close to is that trial ran the risk of being negative because it used such a low dose. The reason why it was a positive trial is because it was massive. Yeah. So when you have a huge trial, you can detect small benefits, right? So had it not been a massive trial, it would have been a negative trial. And you know what we'd still be doing? Tylenol and fluids.
Right. And
I'm sorry, remdesivir.
So this is fascinating. First of all, this is a feature of complex systems, right? The complex system is very sensitive because there's so many inputs to it. So the idea that you could have too low a dose, you could convince yourself that this drug, you came into it, people were telling you this drug will be harmful. So they didn't test a very high dose. They could have tested so low a dose, they wouldn't have seen the signal that it was beneficial, and we would still be telling ourselves it's harmful. Instead, the dose was high enough to detect that it is beneficial, so it is now the standard of care, but the standard of care is too low a dose because they tested one thing and people are afraid to depart from it because of I don't know what.
I just doesn't. And again, it's over relying on evidence and not expertise. So I mentioned one of our closest partners in the FLCCC is Umberto Meduri. He's the world expert at using corticosteroids in lung injury. He's an intensive care physician who's been studying steroids for 30 years. Where's his seat at the table?
Right.
Why aren't they asking him? Like, he has a protocol. We follow his protocol. It's been born of decades of use. I mean, I just don't understand. You know, I made a joke once with my colleagues is that we really want, you know, you can have the NIH, the CDC, and then we want a building for the FLCCC. You know, so just totally. Ask what's the FLCCC? We'll tell you what we're doing on the front lines to treat this disease. You know, while waiting for your big, you know, randomized controlled trials that you're in love with.
Well, I mean, I know you're joking, and I know that you're not joking.
Exactly.
Obviously, the idea that it's different if you're talking about a disease that has been treated for 50 years on which the treatment regimen has settled, and maybe there's something that new comes along, but we can officially find out what that new thing is. This is a different case. Everybody's a novice, right? So why aren't you clinicians at the table? Right? That's preposterous.
And why aren't they doing more trials on these? Why don't you test 6 milligrams of dexamethasone against a higher dose? Like, no one's getting placebo. It's a reasonable thing to do it. I wouldn't go in that trial because I'd want the higher dose. But I think there's enough clinical equipoise amongst doctors that you could easily randomize people, and you could find what the most effect. Where is that effort?
Right. Because obviously it would save lives to know what the most effective dose is.
Maybe COVID's not a problem. I guess they don't feel it's sufficient enough of a problem to study this. But
right. We're on a war footing, but they're not taking it as a priority.